So for those of you that I have not met, I'm Meg Garrett-Reed. I'm the Executive Director of the Office of Affordable Healthcare, a new office here in the state of Maine. I'm very excited to welcome all of you in the room and those of you who are online to our first annual public hearing for the office. I wanted to start by just giving a quick overview of the plan for today. First, I'd like to give an overview of the office itself. I know that there are folks joining us for whom the office might be new, so just to give you a sense of our structure and our duties, a little bit about the guiding principles that I'm thinking about for the office, and then just quickly review the purpose of this hearing. I'll then move into a presentation on the landscape of healthcare costs here in the state of Maine, using some state and national data to help inform that conversation and give a little bit of insight into what we've been discussing, and then move into the public comment portion of the hearing, which is a highlight for me. Just as a reminder, for folks who aren't able to be here in person today, written comments will be accepted through Friday, October 6th. I am unfortunately still waiting on the state's web vendor to publish our website. So in the meantime, very grateful, Consumers for Affordable Healthcare actually created a page on their website that has all the instructions for submitting comment. So I thought I'd reference that. You can find it on their homepage too, is the easiest way if there's anyone who is joining and doesn't have that information handy to find it. Would love to have as many comments submitted both in person and in writing as possible. So moving along to an overview of the office, briefly, a little bit about the authorizing statute and the structure of the office. A law was passed in 2021 creating the Office of Affordable Healthcare, and I included the statutory reference here for folks who might want to take a closer look at it. The office is established as an independent state agency. That's definitely been a point of some confusion. The office isn't part of the Department of Health and Human Services. They just have this very lovely meeting space that I like to use. It's an independent agency, but it works under the general policy direction of the Committee of Jurisdiction, which is the Health Coverage, Insurance, and Financial Services Committee, as well as an advisory council. Quickly about the Advisory Council, there's many members here in the room today. I won't run through the whole list, but thought I would share those individuals' names for anyone who may not have seen that or been able to find it easily. The Advisory Council includes 11 voting members. They are appointed and confirmed by the legislature to represent certain areas of expertise or industries, stakeholder groups. And there's also representation from the Department of Health and Human Services and the Department of Administrative and Financial Services. Those two commissioners are non-voting members and have both designated individuals from their staff to join the Advisory Council. There's a lot in the statute about the duties of the office, but I did my best here to sort of summarize those duties in a more concise way. So simply, the office is directed to analyze healthcare cost growth trends and healthcare spending trends, and to monitor the adoption of alternative payment methods in Maine and nationally around the country. The office is also directed by the establishing law to develop proposals with the potential to improve the cost-efficient provision of high-quality healthcare, improve coordination, efficiency, and quality of the healthcare system, improve consumer experience with the healthcare system, and improve healthcare affordability and coverage for individuals and small businesses in the state. Finally, one additional duty of the office is to provide staffing assistance to the Maine Prescription Drug Affordability Board as well. So it is a wide scope of activity within the sort of jurisdiction or focus of this office. To briefly cover some of the sort of firm deliverables required in the establishing law, one is that the office must hold an annual public hearing before October 1st, part of the reason that we are all here today. We are also required to report annually to the governor and to the HCIFS committee on our activities, as well as input received during this public hearing. There's also a one-time requirement to study policies aimed at improving healthcare affordability and coverage. That was amended might not be the technical term, but there was a resolve passed during this past session to sort of clarify and add some specificity to that requirement, which directs the office to provide a study of publicly administered public option models to the HCIFS committee this coming January of 2024, and sort of pushing back the study of other different types of models with the potential to improve affordability to January of 2025. So I just note that as a priority that the office is engaged in over the next few months to be able to deliver that report. Talked a lot. Briefly, I wanted to chat a bit about guiding principles that I developed for the office and have discussed with the advisory council. And really the intent of these is, as I noted, the charge of the office is very, very broad. There is a lot of work that could potentially fall under this office's mandate. And so I have been trying to think about, as the office evolves and develops and begins to create a policy portfolio, how to evaluate different ideas and policy options for inclusion or for focus by the office. I'll also note the office is currently just me. There's a couple other positions authorized that are going through sort of the bureaucratic process to be able to be posted publicly and to hire for those positions. So hoping that will be changing in the next few months, but we're a small office and so resources are limited. So asking myself sort of where are places where we can contribute and make the most difference. So the first of those in my mind is what I refer to as focusing on the big picture. So that means to me thinking about opportunities where there's the most opportunity for significant, meaningful long-term impact, trying to think about sort of the more transformative big ideas in the healthcare affordability space. I also use that as sort of an umbrella to make sure that we're referencing and thinking about the complexity of interdependent systems in healthcare. Oftentimes, I know with proposals, you can get very focused on maybe one payer or one service or one aspect of the healthcare system. But again, trying to think about this office's work as an opportunity to think a little bit more holistically about the system and about interventions that can touch different points and aspects of the healthcare system. Another really important principle for me is defining affordability from a consumer perspective. So wanting to focus on cost control policies that really provide relief for end payers. So that can mean individuals and families, businesses, government. I think there's importance to savings across the board for those end payers. We know when government is spending a lot in healthcare, that constricts the ability to spend in other areas that might be important. But I really want to put a particular emphasis on consumer cost burden and places where affordability is presenting a barrier to actually accessing and utilizing care and having good health outcomes for our population. The other element of this for me is sort of trying to steer away from, close out of that, but steering away from policies that just shift cost instead of really addressing the root causes of high costs and high spending. And one element of that we discussed in advisory council meetings is, not thinking just about further subsidization of the system as it exists now, but actually getting at that root cause and helping to sort of bend the curve on cost rather than paying for it from a different payer. Finally, the last of these guiding principles is delivering results. For me, that means taking into account whether policies are achievable and really thinking about implementation. I'm coming from a position previously where I was very focused on implementation here at the department when we started up the state-based health insurance marketplace. So I know that when you're developing policy, you can't necessarily answer every single detailed question, but I think it's really important if the office is going to promote a policy solution that we have a roadmap that we really understand and feel confident about the ability to implement. Finally, another important one, they're all important, but recognizing that continuing the status quo is not sustainable. And what I mean by that is, again, I know in this space when we talk about new ideas, new policy changes, it can be a little scary, that disruption in the system can sometimes have unintended consequences, and that sometimes there's a reflexive desire to think about challenges with new policy approaches. But it's important to me that, we in the advisory council group, when we meet, and broadly, I think in conversations like this one, recognize that we can't continue with the way things are, that it really is a strong mandate from constituents in the state, from the people of this state, to change and to do things differently and to deliver some meaningful impact for that. So just briefly, thoughts on the purpose of this hearing. The first purpose is to share the work of the office in my mind. So that's why I have a presentation prepared to just talk a little bit about the available data that we have on health spending and analytics. I think that this is something that will definitely evolve over time. The office is still quite new. I was named as executive director earlier this year. and we had pretty limited resources. The legislature very kindly and graciously provided some additional funding for analysis by this office that will come into effect and be available when that budget becomes law, and we are able to go out and procure some additional analysis. So I anticipate in future years having more original analytical work to present at this public hearing, but in general, just always see it as an opportunity to make sure that there is transparency into the office's work and sort of an opportunity to share it more broadly than the advisory council meetings, which are public, but which, you know, everyone's not going to be able to make it to maybe every couple of months. The other purpose is to, of course, very importantly, provide a forum and process for soliciting comment from a broad array of stakeholders. And I did want to share, you know, my thinking about what that informs. I know sometimes coming to these things, there can be a question, you know, what am I sharing my feedback for? So there's a few really distinct purposes in my mind. The first is that we're actually statutorily mandated to include a summary of the comment that's received at this hearing in the annual report that we're providing to the legislature and to the governor. So there's a very clear and direct relationship there. I think that the feedback that we receive will help to inform the analysis and interpretation of data on spending and costs as we continue to undertake that work. And then finally, the office does have a policy development requirement too, so also can help to inform what the office prioritizes in terms of initiatives or even just problems to solve. Lastly, I'll say, you know, I think just broadly, also from my experience over the last few years, I think there's lots of interaction, obviously, during the legislative session, but it can be very reactive. There's a lot of time pressure crunch during those times, I know. So I hope that this can also be a little bit of an opportunity and a forum to take a step back and have conversations about the big picture again, about really being solutions oriented and dreaming big a little bit about fixes to problems rather than needing to be hyper-focused on a particular legislative proposal that might be coming up in a hearing. So I know there's lots of opportunity to provide input during that legislative process, but I see the purpose here being a little bit different. So moving into a landscape of healthcare costs, I wanted to start with some data on health expenditures per capita comparing the United States and the state of Maine. This data is from the National Health Expenditures data. So this is a pretty comprehensive measure of spending on all aspects of personal health care. It's not just premiums or not just claims. It's much more comprehensive than that. As you can see, that Maine's per capita spending is higher and has been higher than the US average for a long time and has also been growing at a slightly higher rate. And Maine currently has the 10th highest per capita health expenditures in the country. A little bit of extra insight into that data is that thinking about the different components that make up that spending, spending on hospital care is the largest percentage of that total health spending, followed by physician and professional services, and then prescription drugs. So you can see, you know, a very outsized piece of that pie is hospital care. I'll also note, just in comparison to the US breakdown and the US average here, hospital care and then other health, residential, and personal care are the two components of spending that are higher here as a percentage of our total spending than they are in the US average. All those other pieces were a little bit lower in terms of the amount of we are spending or the percentage that we're spending, but hospital care and that other residential care, which would comprise things like home and community-based services through Medicaid waivers and also non-nursing home residential care are the two places where we spend a little bit more.
May I ask a question?
Sure.
Is that Medicare, Medicaid spending, or is that all spending?
All spending. And I should have said, if folks have, you know, clear, just clarifying questions, happy to take those. I think if there's broader thoughts, feedback, I'd ask everyone to sort of save those for the comment time and, you know, submit them if you want to. I just want to make sure that we kind of keep moving, and it's a big group here today, but if there's just a simple clarification, I'm hoping to have.
Yeah, could you say one more time which expenses comparatively to other, I understand overall we're 10%, or highest, but the individual expenses, you kind of quickly said which ones were kind of on par with and which ones were above. If you could say that again.
Yeah, sure. Happy to do that. It is hospital spending and then other residential care. And those are the two where it's not necessarily that our spending is higher, but those two types of services comprise a higher percentage of our total spending than other services. Exactly.
Okay, thank you.
So moving on, I wanted to briefly pause for a minute and say a huge thank you to Maine Health Data Organization. Back before I was named executive director of this office, but after the office had been established, MHDO created a baseline report that came out late last year to sort of serve as a baseline and a start for this office's work. That's available on their website. There's lots of great tools that you can use to dive into the data a little bit more and cut it in different ways. And they very graciously worked hard to provide me with an update to that data to share today that adds the year 2022 to several of the measures. They're working on releasing that, and I think plan to by the end of this week. But in the meantime, I wanted to share a little bit of that during this presentation. There is one quick note on that, which is that Medicare data for traditional Medicare hasn't been released by CMS yet. It's not available to states or the public, so they weren't able to incorporate an update there, which is why you'll see 2022 missing on that measure. But I did think it was really interesting to be able to take a look at 2022 in the context of this data. As we all, I'm sure know, 2020 and 2021 were really unusual years. There was a big drop in utilization in 2020 because of the pandemic, and then sort of a resurgence in 2021 when people were more comfortable visiting medical facilities for things like surgeries or maybe preventive care. So we've seen that borne out in this data, and I was curious to see what would happen when we added 2022. As you can see, there's pretty consistent growth in total commercial spending and per capita spending to some extent as well, recognizing that reduction that we saw in 2020. That's also a little bit different. The total spending, of course, in Maine Care increasing, but per capita changing because of differences, I think, in that population, especially because of expansion.
You don't have Med Sup listed there. Is that lumped into Medicare, or is that just another source that needs to be added?
I'm not sure on that. I would have to check with Karen Lee on that, on their data sources. So I just wanted to share this. I think it, again, is a good way of just showing, I think, general trend. I should mention to you, for those who might not be familiar with Maine Health Data Organization, the source of this data is from claims data that's mostly submitted to MHDO, or in some cases that they collect. It's not totally comprehensive. There are some commercial insurers in particular that are in the large group who aren't required because of some nuances in federal law to submit that information, although they have a pretty significant segment of our commercial market in this data. So I think broadly at a high level like this, it's probably pretty representative of spending, but this would only reflect payments, from an insurance company, from individuals to a healthcare provider. It's not quite as all-inclusive of expenses related to healthcare as that national health expenditure data is. Another data point I pulled from that analysis and presentation was some per capita spending data by county here in the state. This is just limited to commercial insurance, but it shows, I think, what many of us might suspect, that while there's been some changes in general, our more rural areas of the state do have slightly higher per capita spending than some of the more urban areas. This is based on the location of the home of the individual patients, not the location of the provider that's being paid, which is helpful to know when looking at it. One thing we don't know here is the extent to which this is driven by differences in utilization or the health of the population versus prices. That's an additional question that isn't answered directly in this data set, but I think is worth exploring. But just thought that was interesting to pull out again as a little bit of confirmation of what I think many of us discuss and recognize about healthcare cost and spending in the state. There are some differences, I will say, in the different payer sets, looking at Medicare and Medicare Advantage, very similar to this sort of geographic distribution. Medicaid spending is a little bit different there. Per capita spending is a little bit higher in urban areas. Urban by our definition in Maine, sort of the 95 corridor. I also pulled out age, spending by age category. Again, just limiting it to commercial insurance because it's hard to adjust for all the variables and include everything on this chart. I'll just note this is showing year by year change. So you kind of want to be comparing those 22 numbers to each other, 21 numbers to each other. Again, probably not unexpected that both total and per capita spending increase with age through age 64 when there's a pretty significant drop off as folks transition over to Medicare coverage. But again, just thought it was interesting to see, you know, the really significant change, especially between that younger adult category and older adults in the 50 to 64 demographic, which is a conversation we've had a lot in our advisory council and in general, that when we're thinking about health spending here in the state of Maine, one thing we need to think a fair amount is our aging population and the fact that we do have, you know, a larger population of boomers who are just coming into that age range and right now, you know, potentially utilizing more healthcare and more expensive healthcare. So I wanted to move on to another section of the presentation, talk a little bit rather than sort of writ large about spending, more about consumers' experience with health costs and health spending, which generally, not for everyone, but I think in many cases, consumers experience through costs associated with their health insurance, especially now in Maine, where we have a very high percentage of our population insured, which is a great development here. So briefly, this is from the Maine Development Foundation, a graph of health expenditures as a percentage of total personal expenditures. As you can see, some reduction here over the past few years, which initially it sounds great. I think you need to think about that in the context of whether that's a decline in spending, which seems unlikely, or potentially more likely the impact of spending on housing here in the state, which we know has been growing quite a bit, especially since 2020 or so, as well as other household costs like groceries, which are going up. But one thing I'd point out, in addition to the trend here over the course of years, is just how high this is. I'm looking at that axis on the left. It starts at 14.5%. So we're talking about over 17% of total personal expenditures being devoted to healthcare, with significant amount of what people are taking home and what they're spending their money on. And the other piece to point out here is Maine is exceeding both the US and New England averages here. Moving on, a little bit of sort of a dive below that, looking at premiums for employer-sponsored coverage in the state. So this is limited. It's not the entire commercial market. It's not looking at Medicare Advantage, but it is a large percentage of, you know, our population under Medicare age are covered through employer-sponsored plans. Of course, I'm sure no surprise to anyone that those premiums have been increasing over the years. Increase of 30% for total premiums since 2017. And then average employee contributions for coverage rose 35% over that time period. And I think if you look at the individual market, you see similar, if not larger, cumulative increases. In addition to premiums, which for a long time I know were the focus when talking about the affordability of insurance for consumers, I think just based on my own experience of working with consumers and hearing from them, increasingly more and more consumers are sensitive to and feeling the challenge of deductibles. We know there's a trend broadly nationally in health insurance and certainly in the state of Maine towards higher deductible plans in order to help control premium and sort of blunt some of the premium increases by creating higher deductible plans, creating HSA eligible plans. So I just wanted to note here, again, a national trend, but Maine is on the higher end here in terms of highest average deductible for employer-sponsored health insurance plans. One thing that we've talked a little bit about in the advisory council is employer contributions to HSAs and the extent to which that might be offsetting for some consumers higher deductibles in their employer plans. Unfortunately, that data is very, very hard to get a hold of. It's not really collected in any standardized way by the federal government or here at the state level. You know, I think there's evidence definitely of differential impact and use of HSA is based on income. So higher income individuals much more likely to be getting contributions, to be contributing themselves, and if they need to, using those accounts, but really challenging for lower income employees who aren't necessarily having a great deal of funds to put into those accounts themselves. But it is something I'm interested in trying to explore and get a better handle on, but there's a reason why we haven't been able to yet, and it's because that data is just very, very hard to come by. So have to rely a little bit more on anecdotal, I think, feedback from consumers, which does in general show that there's lower levels of satisfaction with health plans that have high deductibles versus more comprehensive, sort of lower out-of-pocket cost plans. This is just following on and sort of trying to combine those two data points to look at both premiums and deductibles as a percent of income, comparing multiple states. One thing I thought it was interesting about these maps was, that Maine was a bit of an outlier even back in 2010. Of course, again, this is a measure that's a combination of what those costs for premiums and deductibles are, as well as the income of our state. We do, I think, have a lower average income than most of New England, but you can see we're really stand out here and continue to stand out here in terms of having upwards of 12% of income being devoted to premiums and deductibles. So a few slides next on the question of why this is, which I know is one that particularly the legislators that I've interacted with are very interested in. I would say, again, much more work to be done on Maine-specific data, but there is some national data that I think can help to inform this conversation, to begin to formulate questions and thoughts about the answer to that question that I thought I would review briefly. So thinking about how medical spending compares to other goods and services, wanted to point out this trend here that over time, for a long time, including long before the COVID-19 pandemic, the inflation and increases in costs for spending for medical care have been much higher than sort of general inflation and higher spending on other goods and services. And that really suggests to me, and I think we can sort of draw the inference, that there are factors that are unique to the healthcare sector that drive those increases, rather than it just being an issue of, input costs, and there's a variety of costs that sort of drive up healthcare spending, that certainly there are factors in this industry that are unique and worth focusing on. There's also always lots of conversation, I think, about comparisons between spending and outcomes here in the United States and other comparable countries, generally defining that to mean countries with relatively high GDP, fairly wealthy countries. No surprise, I'm sure most folks here are aware that we spend a lot more than any other comparable country without having any better outcomes, and in fact, generally worse health outcomes than they have. You can see here a little bit about the drivers of that difference in spending, and actually there's an additional illustration that I think pulls that out even more, that really that difference in spending is driven most significantly by inpatient and outpatient medical services. We talk a lot about administrative differences, and definitely there is more efficient administration generally in those other systems, but just because of the sort of amount of money that is going into medical claims, administrative differences are a little bit dwarfed by that differential. And similarly would sort of point to prescription drugs and medical goods. Again, I know we've discussed a lot of very different ways that other countries price prescription drugs, and it is a factor here in why our spending is higher, but it is relatively low relative to that inpatient and outpatient difference. Yep.
Does the administrative number include the administrative costs that providers and hospitals have to bear?
Yeah, I looked into this a little. It certainly incorporates things like individual staff who are tasked with billing, for example. I think that there are some difference here. I was trying to find out if they have any way of capturing, for example, if you have a single physician who might have staff who are doing double duty between some medical services and some, and I don't think that that is captured, but certainly it captures the administrative cost of having the solely staff dedicated to administrative functions. briefly in thinking about, again, that question of, okay, in higher costs for inpatient and outpatient care, a fundamental question, which I am interested in answering definitely as part of this office's work, is that can really be driven by basically one of two things or a combination of two things, one being utilization, just generally the volume of care that people are using, and to some extent, the site of service that they're using. If someone is utilizing services in a higher cost setting, then they maybe need to be, that's sort of one category that can be driving increases, the other being price. And I think logically, it's likely a combination of those two things that drive the higher spending here in the United States relative to other countries. One, I think, piece of work that's really interesting on a national level is this work by the Healthcare Cost Institute. They have access to a large set of claims from commercial carriers, Kaiser Permanente being one, some of the Blue Cross Blue Shield plans, so representative of many millions of commercially insured individuals, and do analysis of those claims to try to uncover some of these questions. So this data is not representative of Maine claims specifically, it's a broader national data set, but in their analysis, they found that over time, increases in total spending were driven by about 7% of that was inflation, while rising prices accounted for about 56% of the change that they saw between 2017 and 2021.
What does service mix mean on this graph?
It means within service categories, what actual services are being used. So I think the best example would be like in the prescription drug category, moving from a branded drug to a generic, which was actually part of what was called out here, as they noted that service mix was a source of savings actually, and offset some of the spending, and they pointed to maybe, I would guess maybe some biologics based on that timeline, but that being one of the factors that could have driven that. And finally, just while we're discussing the issue of prices related to that graph and in thinking about uncovering the utilization question versus the price question, definitely as we discussed in aging population and the higher utilization there is likely part of why we see higher spending here in Maine relative to other states. We do also have higher hospital prices here. Our average hospital prices are 275% of Medicare prices, and that puts us 18th highest in the country. That's one measure. There's lots of ways of looking at prices, but using Medicare as sort of a benchmark as a price that is developed considering input costs as well as regional differences could be a helpful benchmark in understanding how prices compare nationally. I will just note, I've had the question before, prices in this context, meaning actually what payers are paying to the hospitals, not necessarily a list price, but the actual payment amounts. This is the last section, and then I'll hand it over and let some other folks speak for a little bit. But briefly, I did also want to talk about how healthcare costs are impacting Maine people and give a lot of credit to Consumers for Affordable Healthcare. I pulled much of this, or really all of this, from a survey that they conducted in December of 2022 of Maine people. It's looked like great work, good representative sampling, and I know that they have a full presentation on this available, so if you have questions about methodology or want to see, there were many other questions asked that I didn't include, would direct you there. But in thinking about this office's and this hearing's charge to think about what are barriers to affordable health care, thought this was a great way to incorporate a little bit of sort of voices of actual people being asked about this. So to start, I thought really interesting that 70% or nearly 70% of Mainers believe that just one major medical event or illness would bankrupt them. And that's even if they were able to continue working. Really speaks, I think, to the anxiety and fear that many folks have about the costs associated with healthcare. And also jumped out to me that over half of the respondents noted that they'd be more likely to seek and utilize medical care if they didn't have such high deductibles and out-of-pocket costs. And it just connects back, I think, to that guiding principle, and that sometimes these conversations, I think, can become very academic, and we can think about those graphs on overall system costs, but remembering that there is a very direct human impact to this that is pretty urgent for all of us to work together to solve. For individuals who did not have insurance, I think there were some follow-up questions asked about why that was. Probably, again, not surprising that it was financial drivers that really were the most significant factor for individuals who didn't buy insurance. But I did think it was interesting here, of course, premiums being that initial barrier to signing up, not surprising that that would be the most significant factor, but those high out-of-pocket costs are catching up there. And again, I bring the experience of having worked at the marketplace, and I know for some of our carriers, they probably hear this too. Sometimes it can be hard when you're working with someone who's going to have to squeeze to pay that monthly premium, and then they say, but if I go to the doctor, I'm still going to have to pay this out of pocket. What is the value to me of insurance? So I think that's going to continue to probably, on the current trajectory, be a trend that we hear from consumers. We'll also note that the difficulty in applying for health insurance, definitely an area of passion for mine and a concern area I know lots of folks are working on. So there are other non-financial barriers, certainly, but clearly those financial components are the biggest factor that's preventing our remaining uninsured folks from signing up or enrolling in coverage. For the individuals who did have insurance, there was also a question about whether or not they had difficulty in paying for certain components of their health insurance. Again, it just tracks here that deductibles really jumped out as the biggest challenge for them, alongside medical expenses and prescriptions not covered by insurance. I'm really curious to dig in on that a little bit more and understand if there's particular expenses there that really aren't covered by insurance, or if potentially there are gaps in folks' ability to navigate their insurance to get services covered, to better understand that, because that's a bigger component here than I had expected. But I think it helps to answer that question again about, what are barriers to care, and it's certainly just that initial out-of-pocket hit when seeking care continues to be a big struggle for folks. And finally, again, pretty stunning to me that 60% of the families surveyed reported that they'd been financially impacted by unaffordable medical expenses, and impacted financially meaning experienced one of these categories or challenges that are listed here in the chart. And close to half of Mainers also reported having medical debt. Again, we hear a lot about medical debt, but I was pretty stunned to hear that many individuals were experiencing that. As you can see here, a few different experiences that jump out: struggling to pay for other basic necessities, and probably not a huge surprise given that we know how much budgets are being squeezed right now due to general inflation, using most or all of their savings, incurring credit card debt, and then 30% having been contacted by a collection agency was another that really jumped out to me. That's a pretty frightening and significant experience to have it, and a large percentage of respondents shared that. So I'm going to pause and hand it over. Yeah.
Just a clarifying question on that last slide. And this is all MAID people, regardless of the type of coverage.
That's my understanding. Yeah.
And so we know half of people are covered by government plans, public plans. Okay.
Yeah, I'll look over to Anne if I'm wrong, but yeah, this one was. Oh, good timing for me to have a frog in my throat just before I hand it over. The last thing I was just going to share, I touched on this a few times during the presentation, but again, I'm really excited about this opportunity that the Office of Affordable Healthcare has to conduct more analysis over the course of the coming year. So wanted to know kind of 3 categories and areas that I think, through feedback from the advisory council and just generally thinking about this work, really targeting for that analysis in the coming year. The first of those is trying to get a little bit more of a comprehensive understanding and handle on commercial healthcare, health insurance spending and prices, premiums, out of pockets. There's lots of different data sources for that information, but not a lot where they're really brought together. So a project that we have underway is working with an outside entity to do a little bit of modeling and get a clearer sort of single resource where we can look both at sources of coverage, our remaining uninsured, and barriers that they face, but also what a premiums and out-of-pockets look like. And I'm hoping that maybe through that project, we might be able to, again, we probably won't have totally definitive data, but maybe understand that HSA question a little bit better. The second, which I also mentioned, was analysis of public option models, which again was a directive from the HCIFS committee. So working on a few different models of what that could look like. Very specifically, they're interested in Medicaid buy-in type proposals that are either a direct expansion of Medicaid but financed slightly differently, or built on kind of the chassis of the state's Medicaid plan, but with a premium and a little bit more of a commercial aspect. And then additionally, a publicly administered plan, but that would sort of stand alongside other commercial insurance options on the marketplace and be eligible for financial subsidies. So there's a little bit of a continuum there of proposals that we've been asked to study. So working on that. And then the final component, as you can see, there's lots of questions, and I reference this interest in utilization versus prices. So digging a little bit deeper on that claims data and looking at those components, we can answer those questions more clearly, as well as looking at geographic differences, provider and facility differences. So getting a level below that sort of high level state or pair by pair kind of measures to be a little bit more granular with that data and begin moving towards asking or answering the question of not just what's happening with spending in the state of Maine, but why that is. So I will stop there. Yep.
Two quick questions. One, is this presentation available online to dig into the graphs a little bit and see the numbers that we can't see from here?
Yep, so unfortunately, if I had a website, I would be putting it on there. That's the challenge. I think if anyone signed up to comment or is online, I can send the presentation around to all of them. So if anyone didn't sign up to comment, wants to make sure to get it, either come see me or send me an email. Hopefully you all have my email from the invite to this, and I'm happy to share that. And also I do have a little interested parties list that I've been gradually growing, so happy to add folks to that as well.
Just, I don't know why, I don't mean to be this pessimistic, but in all your global numbers and stuff about costs, is there any estimate for overbilling and other fraud and how big that is in those things? Is that something that's of interest here?
That's a good question. I don't know off the top of my head. I guess all that I can say on that is I think, and depending on what party you're referring to committing fraud, right? I think there's a cost benefit analysis that all entities that are overseeing another take on in terms of how much do they invest in overseeing and trying to seek that out versus the return on investment that they get. And I would expect that if there was a high ROI, they would invest more in seeking it out. So it's not something that's been raised to me as a major component, certainly, but I don't have a number or anything off the top of my head.
I can share anecdotally, Meg, that in fraud, waste, and abuse audits that we've conducted, we're finding about 2 to 3% savings on total medical spend.
And is that fraud, waste, and abuse focused on providers?
Overbilling, incorrect charges, literal fraud, waste, abuse, all sorts of different sort of buckets, but cumulatively about 2 to 3%.
Thanks, that's very helpful. Okay, I'm gonna pause it there and let us transition over to the public comment period. I'm just gonna stop sharing here. And I'm going to start by calling up the folks who had signed up in advance to testify. And then if there's others in the room, if you didn't get a chance to sign up, that's fine. I think we'll be able to accommodate that. I am going to ask folks to try to keep it to about 3 minutes. I think we don't have a super long list, so if you really need to go to 5, that's okay. But if you can try to aim for 3, I would really appreciate it. I also don't have any really fancy way of doing timing, so I'm just going to time on my phone and I'll give a little wave if anyone is getting close to their time. So I did set up the little podium here so we can be official. There's mics in the ceiling, and folks have told me online that they can hear us okay. But please try to project a little bit to the room just to make sure. So the first person that I had sign up was Sam Hallemeyer. maybe I can do waiting in the wings. Alex Carter will be up next.
So our emails to you were us signing up, right? It was like there's a form or anything?
Nope. Yeah, if you let me know you were speaking. I think I have everybody, but. And I just asked, I'm sure everyone will, but you know, if you can introduce yourself and if you're speaking on behalf of a particular organization, please share that since not everyone in the room knows everybody.
Yeah.
Great, thanks, Dave.
Hello, everyone. Well, good morning. My name is Sam Hollemeyer. I'm with PCMA, the Pharmaceutical Care Management Association. We're the National Trade Association for America's Pharmacy Benefit Managers. PBMs are the prescription drug benefits. We offer prescription drug benefits for over 275 million Americans in the U.S. I want to thank Meg and the Office of Affordable Healthcare for allowing me to present today. I'm excited to go first today. So I am going to kind of stick to the prompt of the handouts when this meeting was announced. So I will stick to some of the solutions, some of the barriers, but then I will go into a little bit of detail what PBMs are and the services we offer to our patients and payers and providers as well. Pharmacy benefit managers, they secure lower prescription drug costs and enable better health outcomes and offer employees and other health payers benefits and choices and guidance they need to expand access to medications. Pharmacy benefit companies and managers do not set the list price of prescription drugs. I want to say that from the outset. We do not set the list price. And in fact, PBMs exist to drive down the cost of prescription drugs. That is why the PBMs exist. So I'm going to go ahead and start and jump into some of the solutions and then some of the barriers. So some of the solutions that we have, I'm going to limit it to 3. So I want to ensure systems sustainability by promoting competition, and then support and equip clinicians with tools and data to serve their patients, and then enhance patient outcomes to improve the patient experience. I don't have any specific data on barriers as far as geography or the economy of Maine. The only thing I will touch on is just policies that have already been implemented in state law and the proposed state laws that would restrict PBM tools, and also just the high list prices that prescription drugs are these days. Those are the barriers that I have. If I can come up with other sorts of data elements, I'd be happy to share. If anyone does have any questions as I go through my presentation, please raise your hand. I'd be happy to answer it. So let's go ahead and dive right in. So promoting competition. So promoting generics and biosimilars. You did touch on biosimilars a little bit. Biosimilars are not a new concept, but there are more and more coming to the market that offer competition to these branded drugs that are currently have these high list prices. So the most effective way to reduce prescription drug costs is to increase competition in the marketplace through generics and biosimilars. Solutions to how we can make this happen to promote competition is to protect PBM tools such as prior authorizations and step therapy. So prior authorization is often required for drugs with a high list price or a high risk of abuse or overuse, significant side effects, etc. And step therapy is a tool that PBMs have that promote the use of generics, proven safe generics, usually cheaper compared to their higher priced branded drug competitors. Next, I want to go into real quick is just promoting to keep going with promoting competition is promoting pharmacy networks. So when a patient acquires a drug, can impact costs significantly. PBMs build pharmacy networks that can help lower costs, and well-managed pharmacy networks offer savings to both plan sponsors and patients. So we think that everyone should have to be looked at in the pharmacy drug supply chain, including PSAOs when it comes to pharmacy networks, protecting employers and health plan sponsor abilities to make these pharmacy networks, and then promote the use of PBM's mail order. We think that these are very important tools in order to lower costs. Moving on to support and equip clinicians with tools and data to serve patients optimally. Real-time benefit tools is one thing that we promote. Actually, Maine already has in state law real-time benefit tools, RTBTs. They passed this law about 2 years ago, I want to say. I think it's been in effect for about a year now. We think that this is an important tool for to help lower drug costs. So real-time benefit tools, when a patient is in the doctor's office and if they're given a prescription, the doctor can work with the patient on how much their copay might be, what are alternatives. If they need to start that prior authorization process, they can do that in the doctor's office real time and begin that process. Also along these lines with real-time benefit tools is electronic prescribing and electronic prior authorization, and then providing incentives for these real-time benefit tools for providers. And then finally, enhancing patient outcomes and improving the patient experience. Enable flexibility. Allow PBMs and their payers to build benefits that work best for their patients and beneficiaries. So things that we would recommend are supporting use of PBM specialty pharmacies. They offer lower cost drugs compared to retail pharmacies. I already mentioned this, promoting the use of home delivery, and then again, promoting the use of real-time benefit tools. So those are things that can be done specific to Maine. I do want to discuss something that can be done in DC. I know that's not specific here with this, but I think it is worth sharing. So in potential DC solutions are stopping patent abuse. So drug manufacturers have been able to game the patent system through patent thickets and other ways to stop competitors and generics from entering the market. We think that this is something that the US Congress should take a look at in ending this patent abuse. And then being able to ensure that drugs can compete fairly. So along these lines of patent abuse, drug companies do block other competitors and biosimilars from entering the market from the use of anti-competitive tactics used to undermine the market in their favor. So I will follow up with a lot of this. I do have to keep it at a high level. So I do plan on following up with this. So finally, to summarize, and I know this was quick, it's just to increase competition, encourage the use of technology through real-time benefit tools, and improve the patient experience without raising costs. So that was a quick presentation this morning. I was happy to go first, but I'm happy to answer any questions. And I do plan on answering the questions by the due date of October 6th, and then following up with additional materials with some of the things I presented today.
Perfect. Thank you very much.
Thank you.
Appreciate it. Yeah, I'll just say, I know it's quick, high level is great, and certainly I'm sure lots of folks have more detail that we could dig into in the written comments that will be submitted after. So next on my list was Alex. Thank you. Circle back.
Hi, good morning, everyone. I look forward to getting to know some of you a little bit better. My name is Alex Carter. I use she, her pronouns, and I'm a policy advocate at Maine Equal Justice. And we are a nonprofit legal aid provider working to increase economic security, opportunity, and equity for people in Maine with low income. And a big piece of this work is working to improve access to affordable comprehensive health care. I too will try to stick to your template, and we did identify a couple of cost-related barriers specific to people with low income, but I will focus on immigrant access and coverage gaps in my spoken comments today. And I'll try to read a little bit just so I stay on track with time as well. But while the legislature and current administration have taken really important steps to improve access to affordable health care recently, including the establishment of this office, there are still a group of people who are categorically excluded from utilizing Maine care benefits based solely on their immigration status. These Mainers include green card holders and certain victims of abuse who arrived in the US less than 5 years ago, asylum seekers with pending cases that is a topic of large conversation with or without employment authorization, and those who are undocumented or have uncertain or temporary protected status. The ability to qualify for public insurance, and in many cases private insurance or even subsidies on the marketplace, is the single greatest cost-related barrier for immigrants in our state to getting the health care that they need. Those who fall into this coverage gap need to turn to a patchwork of safety net providers and emergency Maine care in our state as really the only way to access a very complicated healthcare system. This forces a lot of people to overutilize emergency services or rely on free care, often delaying necessary care and turning to hospitals when they could be better served in other settings. And this also actually increases the healthcare costs for everyone in our state, and I will allow you to read a little bit more of that. If we ignore healthcare needs today, we're still going to be paying for higher healthcare costs down the line after conditions have gone undetected and untreated. And I will note there's some related things about free care, but in terms of characteristics that are specific to Maine, we have a small but diverse and growing immigrant population in the state, many of whom are ineligible for federal Medicaid. And like most states, there are correlations between negative health outcomes and race and ethnicity in our state. And sadly, I think many of us are familiar at this point that at the height of the COVID-19 pandemic, Maine had the unfortunate distinction of having the highest racial disparities for COVID infections in the country. And although I really want to be clear that although not all immigrants are people of color and not all people of color in Maine are immigrants, a higher proportion of those who would qualify for Maine care but for their immigration status identify as Black or Brown Mainers. And we cannot fully address racial health disparities as long as a systemic inequity persists in our state. I'll also note that multiple other states have moved to expand state-funded coverage to more or all of their immigrant populations through various mechanisms to larger groups than Maine, although we did take a significant step forward by providing Maine Care and CHIP coverage to pregnant people and children under 21, regardless of status. And we're already really seeing the positive impact of this change in our community alongside our immigrant-led partners. I will just end by saying that the policy, I think, is clear in my comments, but removing immigrant exclusions to Maine Care program so that all income eligible adults could have access to Maine Care would eliminate this significant barrier to healthcare coverage and therefore increase healthcare access for thousands of Maine residents. And I'll just say that if we believe that all Mainers deserve better and more affordable healthcare, as many of our public officials have stated, then we must include everyone in that definition, no matter their immigration status. Thank you.
Thank you very much. Up next, we have Jeff Austin, and then on deck, Trevor Naki. See if I can get the camera working while you come up, Jeff.
Zoom right in really tight for Jeff.
Sorry. Getting there.
You'll hear me, Dan.
Maybe it'll figure it out. They can at least see something now, so I won't hold you up.
So do you give me the hand signal that I've run out of time?
Yes, I'll try and give you a 1 minute if you hit 4 minutes.
Good morning. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association. I appreciate the opportunity to comment. And our comment really is in response to your opening presentation. We would encourage the office to engage in a sort of public conversation about the data and the data sources. You're at the beginning of your work. You're at the beginning of this office. And I think it would be good, utilizing your advisory council, which is a fairly broad representative group, to really dig into what are the data sources the office is going to hold out to the public as being the ones that we should rely on to understand what's going on with affordability. We don't think that there's a data source out there that's going to tell us that affordability is not a problem. It's a problem for consumers, it's a problem for businesses, it's also a concern for providers as well. Yet understanding the data and knowing the data is important in getting to the whys and the causes. So I think I don't know about the presentation you gave this morning because I hadn't seen it until this morning, but the previous one that was provided to the advisory council had no less than 9 different sources of data. A threshold issue is, should the office use data sources that are proprietary, where you and I can't get at the raw data and look at it? We would encourage you not to use proprietary data sources. We can't verify it or vet it. Simple questions like that. But beyond that, really what we want to do is have you look at the comparison and measuring sticks that you want to use to determine cost. For example, the very first one that was used was a per capita cost comparing us to the United States. But do we want the United States policies? In the US line were all the states that didn't expand Medicaid. That is a difference between Maine and other expansion states. All those states were a top 10 state on minimum wage. In that line on the US is all the states that have nothing more than the federal minimum wage. Our comment to policymakers is often, if you want our output costs to be similar to the national average, do you really want that? Do you want our input costs to be the same too? Do you want us to have the same minimum wage as Wyoming? Do you want us to have Texas's coverage policies? The speaker before me talked about expanding coverage even further. So our concern is always, if you want to compare us to other states on output costs, do you really want to advocate for their input costs? If not, the argument is not to don't use per capita costs as a comparison, but do so thoughtfully. Maybe choose the states that have minimum wage laws and Medicaid expansion laws similar to Maine, so that you're comparing us to the places like we want to be and not to places that you actually don't want us to be. Similarly on international comparisons, we always find it a little ironic that the National Academy of State Health Policy that advocates for affordable health care is located at Georgetown University, which costs $82,000 a year, per year, for higher education costs. The number one driver for hospitals is labor. Labor costs are far and away our number one cost. The workers who show up on our doorstep show up with massive education debt that has to be financed through our salaries. Do we want Europe's higher education model that doesn't have that level of private debt that has to be carried through salaries? If not, then how useful are international comparisons? I'll give you one that's close to home. Publicly being debated right now by the legislature is the level of nurse staffing at hospitals. In Europe, nurse to staffing ratios are 10 to 12. There's 10 to 12 patients for every nurse. In the United States, it's 5 to 1. It's 1 to 5. There's a policy debate going on in Maine to lower that to 3 to 1, 4 to 1. Do we want Europe's ratios of 12 to 1? If not, it's not to say don't ever use international comparisons. Don't use these measuring sticks. But if you want the outputs, if you want the output costs, then there has to be a conversation about the input costs. To simply dismiss those are higher education expenses, our staffing demands. That just sets us up for a failed conversation. So at the outset, we would encourage you that there's a lot of great data out there, and all of it is useful, but it needs to be understood in the right context, or else it won't really be able to influence policymaking in a positive way, in our opinion. I will ultimately put these comments in writing, and I appreciate your opportunity to let me speak.
Thank you. So Trevor is coming up next, and then Jean Gazzetti is the next person.
Hi, everyone. I'm Trevor Putnaki. As Meg mentioned, I am the chair of the Office of Affordable Healthcare Advisory Committee, though I'm speaking today in my capacity as the president and CEO of the Healthcare Purchaser Alliance of Maine. We are a nonprofit organization created by Maine employers and public trusts to advocate for higher quality, more affordable, better accessible healthcare in the state of Maine. We represent about a quarter of the commercial population of the state. So in terms of some of the challenges, I mean, there are obviously many challenges in our healthcare system. I'm just going to focus on a few of them. The first one I want to talk about really is access to data. The first data access challenge we're really finding has to do with the hospital transparency files. Now, hospitals are mandated to post pricing files on their websites under the transparency and coverage rules. And we've begun to dig into those files, and we're finding a lot of issues that basically make them very difficult to use for their intended purpose, which is to compare prices across payers and across hospitals. We're finding significant gaps in data, just missing data. We're finding missing CPT code modifiers so that you'll see different prices for the same service under the same plan type. And the files are in different formats pretty much across the board, just making them really difficult. So I think one potential opportunity would be some standardization around those files. We're also finding a lot of data issues just for purchasers being able to get and share their claims data. A lot of the contracts that purchasers sign with carriers basically classify data as proprietary and make it very difficult to share with third-party solutions that could potentially help address cost drivers and lower cost of care for employers. And then the third data issue I want to talk about is hospital financial data. Now, the Maine Health Data Organization does have some data on the financial health of hospitals, but we're finding it a really incomplete picture of what's going on there. I think, we hear from our providers in the market that they are under a lot of stress financially, and that very well may be the case, but there are also publicly available data sources that paint a very different picture of the financial health of hospitals. And without access to really detailed financial data, like profits and losses on investment income, it's very difficult to design policy solutions that are thoughtful and can be really effective. So beyond the data issues, I think one of the really primary challenges in our market is just the level of consolidation that's taken place in our healthcare market. We have two healthcare systems that control the majority of our delivery system. And that kind of market consolidation, as we see in really all markets, tends to lead to higher prices, sometimes anti-competitive contract terms. It makes it really difficult for employers to pursue network strategies that direct care to lower cost sites of care. I want to be clear that that is a challenge that's partly due to the rural nature of the state. There aren't a lot of independent providers clamoring to open practices in rural parts of the state. And obviously, we need infrastructure to serve patients all around the state. But it is a real challenge, I think, for purchasers who are looking to do more things around network in their benefit designs. So the last challenge I wanted to talk about, and this is sort of one I'm still learning about, but it's becoming a hotter and hotter topic in the purchaser community, and that's the solvency of the Megara program as a result of the merger of the individual and small group markets. The Megara program is meant to reinsure high-cost claimants, initially in the individual market, and now that program is being applied to the merged markets. Section 1332 funding, correct me if I get anything wrong here, Kevin, is basically tied to the impact that Megara has on the individual market. So with a larger pool, the impact gets diminished and 1332 funding decreases. And as 1332 funding decreases, the impact of Megara gets further depleted. And you end up potentially with a downward spiral that could cause premiums to increase pretty substantially for both of those groups. I don't think any of these issues are really unique to Maine, although I do think there are some challenges in Maine that are acute here. I mean, the high cost of care relative to the low average income, I think, makes cost a particularly acute issue in the state of Maine. I think the rural nature of the state is a real challenge. But again, I think there are examples around the country where states with similar challenges are addressing these things, and I'm optimistic that the Office of Affordable Healthcare can find some solutions to these things. In terms of the work that our organization is doing to address these, we are working with hospitals who have been really fantastically collaborative so far in sharing financial data to help our purchasers get a better picture of the actual financial health of our provider systems. We're offering some sort of group purchasing vendor programs aimed at changing payment models for things like orthopedic surgeries, moving them from fee-for-service payments to bundled payments with warranties on outcomes. I'll skip the rest because I want to get to some of the potential policy solutions that we're looking at. I think LD 1708, which is the elimination of anti-competitive contract terms like all or nothing, and anti-tiering and steering clauses would be great. Out-of-network rates should be capped at 1% of Medicare. Having the state mandate a universal reporting standard for hospitals to comply with the transparency and coverage rules, and instituting meaningful penalties for noncompliance, such as not being able to send medical debt to collections. Ensuring hospitals screen patients for free and charity care program eligibility and making the process frictionless for patients to enroll. Ensuring tax benefits do not exceed the value of the hospital's community benefit with a clear definition of community benefit. Ensuring the public has a clear picture of hospital finances, including investment income and losses, and creating a division of the Bureau of Insurance that handles consumer, purchaser, and payer complaints regarding providers. So thank you for the opportunity. Apologies if I went a little over.
No worries. Thanks for talking quickly at the end there. Great, so Jean up next, and then it will be Chris Ossenfort on deck.
Good morning, everyone. My name is Jean Gazzetti, and I am here visiting from Bath, Maine. It looks like I'm the first person presenting who's not associated with an organization. I'm not here for a nonprofit or an agency. I am here to tell a personal story about how I fell through the cracks for healthcare. I lived in Maine from 2008 until 2014. I left due to military obligations of my spouse, and I moved to a few different countries and a few different states. And then I returned to Maine. And part of the reason I returned to Maine was because I went through a divorce. And I was on military health insurance. And when I moved to Maine, I was almost immediately employed as the Register of Probate for Saginaw County. And I stayed on my husband's insurance because I was a single mom working for a government agency and it was cost savings. My husband is a doctor, my former husband is a doctor. And once the divorce was finalized, he said to me, you have a 6-month grace period, which I took at face value. So looking 3 months later, giving myself plenty of time to find new health insurance, I found out that actually the grace period was 60 days, right, for a qualifying life event. And so I started calling everywhere, trying to find just transitional insurance, just something to cover me in the short term. I called Anthem, I called Aetna, I called Blue Cross Blue Shield, I called Community Health Options, I called the Maine Marketplace. There are no options for emergency coverage, none that I could find. My income, because I was working full-time and I also had spousal support and child support, didn't allow me to get Maine care. And so I'm standing in front of you today, having been 6 months without health insurance. One of the things that I also did upon my divorce was apply to law school. So I'm now a part-time law student, and that's why I'm not employed through my employer. Let me clarify that. I don't have insurance through my employer because I decided to go to law school. I did find out that there is insurance available through law school. This is after having been looking for 3 months. That insurance available through law school is $10,000 for the year, which for me means taking out $10,000 in student loans in order to pay for health insurance. And one of the biggest barriers here, obviously, is the idea of an enrollment period. And I can understand conceptually why an enrollment period is necessary. You don't want somebody shopping around for health insurance should they suddenly have an emergency. Like, I can understand that. But if enrollment periods are going to be a strict criteria and you can't get health insurance, now I only went 3 months without health insurance, and I could not get health insurance because 3 months was too long to have been without health insurance. So if enrollment periods are a thing, you have to have options for temporary health insurance. I did look, I tried to find why are there no options, because one of the health insurance representatives said to me, they don't allow it at all in other states, and so we don't offer it anywhere anymore. And so I did find something from 2019 on the Consumers for Affordable Health Care website that talked about changes to short-term plans and a law that had passed to protect individuals who were not able to get the health care they were covered or promised through their insurance. And the result of that is there's just nothing available anymore. So even though trying to make it better, I can tell you, I mean, I have a bachelor's of science in biology, I have a master's of science in natural resource management. I'm in law school. Like, I really tried to do everything I could to find health insurance, and my only option was to take out a $10,000 loan. So that's my comments for today.
Thank you for taking the time to be here, and I'm sorry about that experience. So next we had Chris Ossenfort. The next person after Chris will be Lisa Harvey McPherson.
Good morning. I'm Chris Ossenfort with Anthem Blue Cross and Blue Shield. I'm the Senior Government Relations Director for our plan in South Portland. I'd like to thank you for the opportunity to present these comments today and the format. I know it's tough getting this off the ground and doing it for the first time, so congratulations on a good start. And we look forward to working with your office and the advisory committee. And I would note that in your opening presentation, there was a lot of talk about premiums and deductibles and how high they are in this state. And that, of course, is because that premiums are ultimately a reflection of underlying healthcare costs. So to focus, and in 3 minutes, and we will certainly submit written comments with more detail and then address all of the factors that you had asked be addressed. But I wanted to highlight 2 areas of concern for us this morning. And Mr. Putnaki touched on one of them, and that is provider consolidation. When health system markets are consolidated, and Maine has a very consolidated market, as he noted, 2 systems control the majority of hospitals in this state. Reimbursement rates are not the result of competitive negotiations. They are the result of significant leverage And there are a variety of factors that contribute to that leverage. And we are seeing this increasingly, not only with hospital systems, but also with specialty providers. Because they have such significant market share, they are able to extract above market increases because we need them in our networks. One policy solution that we would urge consideration of is currently we are not allowed to use telehealth to meet network adequacy standards. And there are some services for which that is appropriate. And there are other services where telehealth is absolutely appropriate, such as behavioral health. But right now, telehealth is not allowed to meet network adequacy. Another policy area that is a concern for us is the certificate of need process. While there may be some merit to the process conceptually, we do not believe that it is working as intended. CON has not stopped the formation of large monopolistic systems, but it has hindered the development of alternative sites of care. So we would urge that some review of the certificate of need process and some adjustments to when certificate of need is reviewed or required and what it reviews would be appropriate. And finally, we would also note that, as Mr. Hallemeyer mentioned, limits on our ability to exercise medical management to try to control costs. We are seeing increasing efforts to limit our ability to use prior authorization, to manage our own formularies, to define what benefits should and shouldn't be covered, and all of those contribute to costs as well. So with that, I think I've hit 3 minutes, and I'd be happy to answer any questions, and we'll, of course, expand on all of this in writing and some additional issues.
Sounds good. Thank you, Chris. And right on the dot, I can tell you have done this before. So Katie, and then up next after Katie will be James Sullivan.
There, good morning, everyone. I'm Lisa Harvey McPherson, and I'm here today speaking on behalf of Northern Light Health. We're proud of our service caring for the people of Maine each and every day. And we are particularly proud of our care during the COVID-19 pandemic. We approached that historic challenge with a culture of yes. Everything that was asked of us, we did, and we are proud of that service. But today we are challenged in ways that are historic in nature. The challenges I will describe are the stories of Maine hospitals, the stories of hospitals nationally. Kaufman Hall is a national financial consulting company that publishes reports on hospital financial challenges. They report that hospitals lost billions in 2022 because expenses increased at an unprecedented pace for labor, pharmaceuticals, and supplies. They estimate that expenses will remain 20 to 25% of pre-pandemic levels. We have set a new baseline on the cost of care. So for Northern Light Health, the financial losses are historic. In 2022, we lost $132 million. Our costs were $168 million higher than the previous year. And during that 1 year period, that same 1 year period, our system-wide costs for nursing increased by $72.3 million. Maine has a nursing shortage. There is a new baseline in the cost of nursing that has reset the market for the future of healthcare. And despite all of the work of our clinicians, our leaders, and our frontline staff, we continue to lose millions of dollars. It will take years for hospitals and health systems to stabilize. So what do we expect as we look forward? Healthcare organizations will rebalance their cost structures to align with inadequate revenues, and services will be discontinued. There will be increased regionalization of specialty services, and the role of technology will expand. Workforce challenges will threaten the long-term viability of all community-based care, the viability of our hospitals and post-acute services. Underpayment for services by governmental payers shifts hundreds of millions of dollars of cost into the commercial market, and that will continue. We talked a little bit about the aging of Maine's population. This older adult population they have cancer, they have heart disease, they have chronic lower respiratory diseases. They present to our system with complex care needs that are expensive. They are the predominant volume of our patient services. But despite these challenges, we participate in a variety of reimbursement models. We are committed to supporting the transformation of how care is delivered and paid for. And I will include more examples, but we are particularly proud of our work as an accountable care organization. And for the 2020, 2021, and 22 period, the period I've just described with intense challenges, we generated a total savings of $9.8 million for the Medicare program. We have a crisis in Maine's healthcare system, and it's not the affordability problem. It's the problem of patients living in the wrong environments of care. On any given day, we have 65 nursing home patients living in an acute care bed for hundreds of days. There is nowhere for them to go. And we have children living in our emergency departments for weeks and months. Our large emergency departments and our smallest critical access hospital emergency departments. These children live there for weeks and months, waiting to access residential behavioral health services. These costs are not compensated, but yet these are real costs. These are real costs that should be reflected in Maine's long-term care system, but they are not. The most expensive real estate that we have in the state of Maine is being used inappropriately because we do not have the policies to stabilize these two levels of care, long-term care and community-based residential services for children. So I ask you, all of us, to be engaged with the equal amount of energy to help us solve that problem, which will immediately have a positive cost impact on hospitals statewide. And I thank you for the opportunity.
Thanks.
How'd I do on time?
You're good, just under 5.
Just under 5, okay.
I'm mostly holding my questions, but something I will ask you in part, because I'm sure you're thinking about it, knowing your background. And if there's thoughts now, great, but otherwise, if it's something I could request in the written comments, you mentioned the workforce challenge. I'd just be really interested if there are initiatives that Northern Light is promoting, trying to get at that workforce challenge and change that trajectory in the long term, and if there's specific barriers, to entities being successful in doing that where the state should be playing a role in helping with that.
We work with every nursing and I'll talk about nursing as broader than nursing. We work with every nursing program in the state of Maine. We're supporting faculty. We provide over 100,000 hours of clinical training time with our own staff in our institutions. And we've supported the policy need to increase the number of faculty. One of the strategies is faculty loan repayment. So we are very actively involved, but we have a pipeline issue. We don't have hundreds of students saying, I don't want to be a nurse. They do want to be a nurse. We have a pipeline problem to create the capacity in our education programs to meet the need of employers as nurses retire out. That's the dynamic.
Thank you.
Okay, thank you.
So James Sullivan is up next, and then after James will be Katie Philip-Norris.
What did I do? Oh.
I was just going to say, if only you had thought about the nursing
So
shortage.
I'm here to speak about my experience with
I know.
employer healthcare. Between my biweekly contribution and my employers, we pay $26,000 a year. And then we have a $5,000 deductible on top of that. Now, I wear a DME, which costs me $500 a month. That's $12,000 a year. Sorry, $6,000 a year. That meets my deductible. I have savings for 2 years. What do I do after 2 years? My insurance will cover 60% of it after I reach the $5,000 deductible. Again, what do I do after 2 years? When I joined the workforce in 1988, you had no copays. You had no referrals. you had very low prescription costs. Our legislature, state and federal, has ignored it. They basically let the insurance companies write the rules. I don't know if any of you are from the legislature, and I am not blaming you. Ball has been dropped for many years. After 2 years, I don't know what I'm gonna do. Do I go to the bank and say, I need a loan for medical supplies? You can't get any information out of the state. I spent 3 hours on the phone for 2 days trying to talk to somebody at MaineCare because I got an ARX plan with no information. Does it cover my DME? Does it only cover prescription drugs? I had insurance through the ACA, but that plan's no longer available. Now, if I go to Cover Me Maine or I go to the ACA website, the best plan I can find would cost me about $600 a month. And it's basically a 60-40 split until I get to about $10,000. Then they will cover it. If I live another 30 years, that's $150,000 out of my pocket. I work for a nonprofit. We have about 500 employees. At $25,000 a year, that's $12.5 million that they would pay in medical costs. And that's just rough math that I did while I was sitting here listening to the other people speak. That's $12.5 million a year. And you're gonna tell me that our provider could not cover 100% of our medical cost? Seriously, that's $12.5 million a year. Now, I'm not saying every one of our employees are covered by our insurance, so the cost is probably lower, 10 million, and we still can't get 100% coverage. There is no insurance plan that covers 100%. I drive out of this parking lot today and somebody hits me and totals my vehicle. I pay $500 and I get a check from the insurance company to replace my vehicle. That's insurance. I die and whoever I leave my life insurance, whether I have the policy for 10 years or 20 years, gets a check for a certain amount of money. That's insurance. What we have nowadays for healthcare is not healthcare. It's basically you have to pay to a certain point and then we will pay. I work for a group home that is funded by DHHS. I make too much money to be covered by MaineCare, even though I am paid out of DHHS's budget at the lowest possible rate. But I make too much to qualify for MaineCare. At that $500 a month, that is about 28% of my monthly net income. How do I keep my house, feed myself, pay my house insurance, pay my vehicle insurance? We're required to have these insurances on our vehicles to drive on state roads. We're not really required to have health insurance. And I know, depending on what party you're from, people will say, well, if the founders wanted you to have health insurance, they would have put it in the Constitution. And I think that's a ridiculous argument because George Washington died of a sanguination. He was bled to death because that was the medical standard at that time. Now, I understand MRIs cost a lot. I've had many surgeries at your hospital, and I've gotten great care at your hospital. And I am not blaming the hospital system. I am saying our legislature has dropped the ball. I am saying our federal legislature has dropped the ball. I've tried to talk to Susan Collins, basically got a form letter. I've tried to talk to Bruce Boloquin, again, got a form letter with no information on help, subsidies, grants, anything I could apply for. I think there are programs out there that would help me, but it takes you an act of God to find them. It takes you an act of God to get somebody on the phone. So at this point, I am going on my employer provided program. And it's basically a roll of the dice. 2 years from now, would I be forced to sell my house? It would cost me more to go live in an apartment. I don't have a giant house. I live in a house appropriate to my lifestyle. So I understand the legislature can't fix everything overnight. I understand that there is no 100% guaranteed solution. I know people would say Medicare for all is socialism. And I don't know what the answer is, and I am not going to pretend to. But this form we have right now does not work. And nobody really listens. I got the runaround from my senator and my congressman. I've tried to talk to my state legislator. I've tried to email her, tried to call her, and never got a response. That's all I have to say. Thank you for listening to me, and hopefully somebody can fix this problem.
Thanks very much for sharing your experience, and I hope so too, and happy to keep engaging on your experience as well. Katie is next, and then Kevin Lewis will be up after Katie.
Thank you, Meg, and thanks to all of you for being here, and thank you, Mr. Sullivan. That's a pretty timely and important story for us to all hear right now. I'm Katie Fulham Harris. I lead government affairs for Maine Health, and which is the largest health system in the state. We've heard about the consolidation. I just want to start by saying how important that consolidation has been, because we have, in being able to bring together practices and hospitals, we're able to provide an integrated set of services across our system and provide access. Because someone mentioned the importance, I think it was Trevor, related to rural healthcare, and access in rural Maine would not exist in the levels that it does today for the health systems that have been standing before you. I am not going to repeat what Lisa Harvey McPherson said, but just to say that the pandemic impacted us in exactly the same way that it impacted Northern Light. So I'm going to walk through some of the questions that were asked in a little bit different order than they were asked. So characteristics, we've heard that Maine's population is old. That impacts us both from a disease burden perspective and from a workforce perspective. We have an older workforce. They're retiring at a faster rate than other states, and they are have a harder time doing some of the physical jobs that are required of healthcare. Medicare, we have the second largest percentage of our population on Medicare. That's important for a couple of reasons. One of which is that Medicare pays us about 84 cents on the dollar. And in the data that you heard earlier today, what you didn't hear is that we're 45th in the nation in terms of per capita spending from Medicare. So the cost shift that has been referenced earlier gets exacerbated when we're 45th in per capita spending for Medicare, and we're 10th in private insurance. And the long-term care needs of our state that Ms. Harvey McPherson referenced really far exceed those of some other states. We have the oldest population, and yet we're the 6th lowest number of long-term care beds in the country, and that's licensed, and as opposed to actually filled. So we really do have a some substantial challenges there. We also have a large geography, I think all of you know, that the extent of Maine's very significant geography. We have 36 hospitals to serve that geography and the 1.3 million people in the state, while there are only 26 hospitals in New Hampshire to serve the same number of people. That costs money. We're relatively poor. New Hampshire is 7th in terms of per capita per CAISA in per capita income, and they have about 7.7% of their population falls below the poverty level. We're 12%. That's a substantial impact on us. And importantly, we're also part of the Boston labor market in much of the state, and that drives costs that are not reimbursed in the state of Maine from a labor perspective. In spite of these challenges, we have some really important good things that in Maine as well, and that really relates to quality and access. I will just note that Maine ranks 38th in the percentage of adults who report not seeing a doctor in the past 12 months because of cost, and that's from the Kaiser Family Foundation. So we do have some very positive things that we're doing. Strategies that we are undertaking to sustain services and address affordability. I want to emphasize what Ms. Harvey McPherson mentioned related to patients boarding in our EDs because of lack of access to behavioral health services and in our inpatient beds because of lack of access to nursing facilities. We've become a temporary home of last resort for many populations, and that is very expensive, both on our care team members as well as from a financial perspective. We're also focusing on efficiencies. So Maine Health will sustain a $15 million loss in FY23, and it's actually $50 million, a net $15 million loss that was mitigated by state and federal one-time COVID relief funds, on top of a loss that we sustained in FY22. And we are budgeting for a loss in FY24. So that's 3 years in a row of losses. In the budgeted loss, which is approximately 3% for FY24 or $125 million to achieve break-even result, we've identified $100 million of mitigating strategies internally to address those costs. So we have turned to the payers for just 20% of that money. We are not cost shifting the entire loss. We are really digging deep and doing everything that we can to address efficiency and ensure that we're providing the right care at the right place at the right time to the extent that we can to mitigate cost. We're also investing in new care models. We are trying to move away from the hamster wheel of fee-for-service models and really try to address the right care for patients that is not being driven by our fee-for-service model. That's going to take some time, but we feel very strongly about that. And aligned with that, we're pursuing value-based care models. Ms. Harvey McPherson mentioned the accountable care organizations that both of our systems have, and we too have been very successful, both with Medicare and with Medicaid. We've saved the state significant amounts of money in terms of our participation in their Accountable Communities Initiative, and we're proud of that. So some of the top state priorities, I will just turn to those that Lisa mentioned related to long-term care and behavioral health. We are going to have a hard time getting our arms around the healthcare costs in the state if we do not get our arms around those two areas. I will end it by talking about the concerns in reducing the cost growth of healthcare. We fully acknowledge that affordability is a great concern to all of us and to our population. Access cannot be realized without affordability, but it has to be equitable access to care. So we've recently seen a large number of seemingly simplistic solutions, both at the state and federal level. Interestingly, the same solutions at the state and federal level that targets very specific populations or issues, such as those with private insurance. These efforts are intended to address just one segment of the population, and we feel pretty strongly that we and hope that we can all agree that that we need to have a level playing field and a level of equity that is foundational to Maine's values, and ensure that the efforts to address cost get carefully screened through the lens of access to high quality care for all Mainers that our current delivery system provides. It is our hospital systems that are providing care to all patients regardless of ability to pay. Second, support for services, and I'm wrapping up. Support for services. We've recently seen OB/GYN services, I think in 5 hospitals in the state of Maine that have had to close. We have to be paying attention to the unintended consequences of some of the policies that are being discussed, and increased administrative burden related to requests for hospitals. So I will be submitting extensive comments related to this. We appreciate the opportunity to testify, and please think about the importance of the unintended consequences and the importance of ensuring that the policies are reflective of the entire population and not just one segment. Thank you.
Kevin, and then after Kevin, Semaine.
Good morning, Kevin Lewis. I'm the president and CEO of Community Health Options. And following Alex's good lead, I use he, his pronouns. For those that don't know, Community Health Options is Maine's nonprofit co-op health insurer. We are now completing our 10th year of operations, having been in the marketplace in each and every year since the marketplace was established. Since our inception, we have offered individual and small group insurance. And in 2016, we initiated our large group market offering. And so we write business in all segments of the commercial market, both on and off exchange. What I'd like to do is first lay out some of our accomplishments, and then point to a couple of the challenges, and then our recommendations, and try and do so quickly, because I do have a good list of 10 recommendations. So over the past decade, we have made considerable investments through our benefit design to advance improved health outcomes while reducing the total cost of care and achieving those outcomes. We pioneered a value-based benefit design that dramatically reduces cost sharing for routine care necessary for chronic disease management. We led the way in making the first 3 behavioral health visits free to members in all non-HSA plans. We pay members to receive infusions at lower cost infusion centers that have resulted in millions of dollars of reduced costs, which in turn gets plowed back into lower premiums for all. And we work specifically to aid members access lower cost prescription drugs through coordinated efforts with their providers, which has reduced out-of-pocket spending and increased access to medications. In addition to cost savings, these and other related efforts at Health Options have led to significant quality outcomes. Our all-cause readmission rates are lower than the industry benchmark. Our adherence rates for chronic care medications are higher than our peers nationally, and we are exceeding NCQA standards for our rate of follow-up following an inpatient behavioral health stay. Health Options is committed to improving health outcomes while reducing the total cost of care. We do this through the tools that are available to us, which include care coordination and utilization management, prior authorization, partnering with providers, and member outreach. I'll skip to a couple of the challenges that are really hitting, and some of these have been mentioned, so I'll be brief, but specialty pharmacy. The cost of specialty drugs continues to be the leading trend factor impacting the commercial market. Legislative constraints in our predominantly fee-for-service market here in the state, the government's curtailment of management controls hampers our ability to influence triple aim achievement. Provider consolidation, the rise of system consolidation and collapse of independent practices has coincided with changes in utilization and practice patterns. I'll also point to a couple of market and policy events over the last several years that have contributed to rising premiums. One is ironically, the merging of the individual and small group markets and its impact on Megara, as Mr. Patnaki mentioned. The further reduction in the value of Megara through the curbing of reinsurance recoveries on high-priced items and services. In the small group market, the acceleration of small businesses moving to level-funded plans. So in brief, the recommendations I have are first to decouple the individual and small group markets. The single biggest factor driving up individual and small group premiums for 2024 is the effect that the merging of the markets has had on Maine's reinsurance program, Megara. Second, increase the small group pool. By changing the definition of small group from up to 50 to up to 100, Maine's small group pool would substantially increase and attain the benefits of a larger, more sustainable block of insureds. Third is to increase the health of the small group pool. And that's really to impose some guardrails around level funding or the self-insurance mechanisms available to very small groups and avoid what becomes a toxic rebound into the community-rated pool, which results in the small group pool becoming the high-risk pool for small business. Make Health InfoNet available to payer participation. Health InfoNet is arguably the most successful health information exchange in the country. It serves an extremely valuable purpose by making critical health information available to reduce waste and increase timely access. While abiding by patient protections of HIPAA, payer access to HIN would aid in care coordination and reduce administrative burden for both payers and providers, and generally root out waste due to wasted spending due to inefficiencies. Fifth is to eliminate the HPIS tax, the high-priced items and services tax on premium payers. This is going to hit in 2024. The cap on reinsurance recoveries to 200% of Medicare payments imposed on premium payers conflicts essentially with the intended impact of this policy. 6, do not place further curbs on prior authorization and utilization management until we reach widespread adoption of value-based care contracting with downside risk arrangements. And I agree, there has been some good momentum, but we need to really achieve that those new systems prior to placing curbs on management techniques that are necessary in this fee-for-service arrangement. 7, do not mandate particular drugs or drug classes. Forcing coverage of a particular brand only further strengthens the manufacturers at the expense of premium payers. And the last 3 are adhere to mandate studies prior to final consideration of any mandates. Encourage value-based arrangements without increasing healthcare costs. And I'll just report more on that. Move to value-based payment systems should benefit the clinicians providing the care and the patients receiving the care, and without layering on additional costs to an already beleaguered market. The entry point to value-based care cannot be the imposition of additional charges. There should be adequate resources within our existing funding to move towards both gain sharing and risk bearing, and applied in ways that allow clinicians to move from volume-based, to value-based. And last but not least is establish seamless, this is right up your alley, Meg, establish seamless enrollment pathways between Medicaid and the marketplace. Despite the unwinding, the Urban Institute estimates that only 5% of those losing Medicaid will find their way into marketplace coverage, while over 20% are estimated to go uninsured. Improving the seamlessness in coverage and greater access to preventive care and good management of chronic conditions will lessen more expensive costs downstream. So I thank you for your consideration, and I look forward to submitting these comments in writing.
Thank you. I'll give you one for follow-up now or in the comments because it's an issue less familiar to me, that access to HIN data, just being clear about what data can be accessed through that you can't sort of access through claims, or how that helps to inform your policies more than your own claims data would be something that would be helpful.
I'd love to dig into that. There's a lot there.
Great.
Having spent 8 years on the HIN board, I've been longing for that information.
Sounds good. Thank you. Smenia. And after this, it will be Dan Demerit.
Good morning, everyone. My name is Saman Ibrahim. I'm a program assistant / community health worker at Maine Access Immigrant Network. Maine is a nonprofit that ensures equal access to health and social services for all. We help anyone who walks through our doors. Our focus is the immigrant, refugee, and asylum-seeking community. Here in Maine, we do this through our 4 program pillars: case management, community health work, advocacy, and community-led research. It is with years of experience in this field that I offer the following comments. As an immigrant-led organization with deep roots connecting us to multiple immigrant communities, we have witnessed over and over the challenges experienced by individuals and families who lack healthcare coverage. I will offer some example from present and past clients I've recently worked with to illustrate some of the most significant barriers to care we see among immigrant communities. One affordability barriers I see is issue with access to free care. It has been my experience and some of my colleagues at Maine that free care is extremely difficult to navigate for members of our community across the state. As a Maine community health worker, I often accompany clients to their medical appointments. I have never witnessed, actually, hospital employees inquiring if a patient has applied or is aware of the free care program. When patients ask for free care applications, they are directed to find one online. However, many of the people that I work with don't have access to a computer, internet, or a printer. In a few times, a patient was able to obtain a physical form. On site, it was in English and not really in their language. Additionally, I have found that there is difficulty for applications depending on the hospitals. For example, one of our local hospitals requires a form as part of the free care application that cannot be found on their website. These barriers make it much more difficult for patients of immigrant communities to enroll in free care, which they are legally eligible. For example, I've helped a community member who had been diagnosed with late-stage stomach cancer. Unfortunately, when she learned as a patient that her free care coverage did not extend to her cancer treatment, she was not guided by the hospital system to exciting community resources built to provide financial assistance to patients with similar situations. Instead, she was essentially left to fend for herself. To find financial assistance for the cancer treatment she needed in order to begin her treatment plan. After she shared this information with me while she was at the hospital, I began to quickly look for assistance programs among partners organizations I knew of that might be able to help her pay for the cancer treatment. The first organization I reached out to is Care Partners, a division of Maine Health with whom our organization has a long history of collaborating. Regrettably, while she was going through the application screening process, she succumbed to the cancer and passed away. In the subsequent section, I would like to offer some policy suggestions of one which will streamline the application process for all free care and financial assistance programs. Doing so will allow this patient's prior approval for free care to translate into immediate enrollment in all other qualified programs, potentially avoiding a waiting time period. This delay she experienced as an illustration of this tragic story exacerbated her urgent need for immediate care. I urge the office to consider expanding and improving access to hospital financial assistance programs. One of the resources identified in the 2022 Cumberland County Community Health Need Assessment that could be used to address issues with access to care in hospital free care to leverage the resources to its full potential. They must be accessible, clear. These programs must be widely publicized, especially in immigrant communities and in hospital settings. Patients should be informed if a service they need or are seeking is not covered by free care. Patients should not have to have documents notarized as part of the application process. Application process to free care and financial assistance programs should be streamlined in order to avoid handling waiting period. Patients should not receive bills that they don't need to pay. increasing the federal poverty line income limit, the patient must fall below in order to qualify, would expand free care coverage for some immigrant community. That means some main hospital already go up to 200 of the federal poverty line. But requiring all hospitals to do so would help enroll more people into the program. By reducing application barriers, language barriers, and barriers in accessing accurate, timely information, more community members will be able to enroll and benefits from the free care. The care for which they are income eligible and needs their life healthy. I appreciate this opportunity for having me and to provide these comments. I look forward to working with the Office of Affordable Healthcare Acts. Merci beaucoup.
Thank you very much. Thanks for your work and sharing the CHW perspective. So Dan up next, and then we'll turn to Christina after Dan.
Thank you. My name is Dan DeBarrett. I'm the Executive Director of the Maine Association of Health Plans. Our 6-member plans, private nonprofit insurance carriers provide or administer health insurance coverage to about 600,000 people. It's very nice to be facing the entire audience, not having my back to people. And I can sense the eye rolling sometimes behind me and at the jokes or maybe even a pertinent point, but it's nice to be facing everybody. And I wanted to thank people who came today to share some of their stories about personal barriers, either cost or our process. I think that's an important part of the discussion that we need to be talking about as part of this work. Meg, you shared a lot of data that was part of my presentation, so it'll shorten my work on this end and the work that I'll do on the back end to provide written comments ahead of the deadline. We appreciate this chance to talk about root causes and solutions we can work on together when we don't have one piece of legislation or one particular policy proposal in front of us that we have to discuss and resulting in friction and perhaps not creates kind of a binary approach sometimes that I think can be challenging. I do think medical volume has tripled nationally over the last 10 years to 49.7 billion transactions. That's one data point you didn't get ahead of me. And I would share that that puts pressure on everybody, providers, payers, patients, taxpayers, employers, consumers. No matter where you sit in the system, there's that kind of increase in volume, those kinds of demands create a lot of pressure in the system. And this big picture discussion is a right approach to how we can move forward. Health plans add value by, we've heard from a couple of them today, add value by connecting patients to value-based care and managing costs for consumers and employers. One of the interesting challenges we all have in healthcare is sometimes we're a consumer or purchaser trying to manage costs, other times we're a patient. And whatever the cost may be, we need access to the care that we believe we need access to. For health plans, it's important to be able to have tools to design, as we have this conversation, the tools they need to deliver that value in the system. And that includes tools to design our plans and formularies, tools to manage utilization and help direct consumers to smart evidence-based choices that improve outcomes while managing costs, and curbing cost drivers that are escalating what we all pay. We hear a lot about drug prices and new procedures, and how do we work together? How do health plans have the tools they need to manage those types of costs? And health plans deliver value by working to strike fair, consumer-focused agreements with providers across the system. We've heard about the rural nature of the aging population, the impact that has on disease burden and workforce. We'd also raise that there are state policies that well-intended but can also prevent healthy health insurance markets and the tools that health plans have to help manage care, both from a cost perspective and an outcomes perspective. So, and we think that to the extent that this discussion leads to better oversight, transparency among all participants, that's a step forward, and we really appreciate the idea that we can come forward, we can all have a different data point that can align with our point, and to the extent that we have a set of data, as Jeff talked about, that we can all sort of agree on, this is the basis that we're talking about, it sets expectations, that'll be an important part of the conversation moving forward. So we'll have a lot more to share in our written comments by October 6th, and we thank you for the opportunity to present, and I'm pleased that Representative Arkwright cannot ask me any questions.
Yeah,
thank you.
Thank you, Dan. So Christina next, and then we will turn to Helen Roy.
My name is Christina Kusumana. I work at Med Access Immigrant Network as a community health worker. Many of my clients I work with are income eligible for Medicare but are excluded based on their immigration status. These clients are unable to afford the costs associated with seeking out care without insurance coverage. Many of those clients push off seeking out care until the last possible moment when medical circumstances have become dire and more expensive to treat. Some of the clients we work with at MEN are asylum seekers who are granted access to Medicare based on their asylum status. However, multiple clients who are asylum seekers have come to me with stories about challenges to accessing Medicare. Many of the clients are told that in order to apply for Medicare, asylum seeker must have proof of their asylum application has been received. Many applicants are left waiting extended period of time of this receipt of asylum application in order to apply for Medicare. One family I work with has lived in Maine since February. They are still waiting to receive proof of their asylum application from Immigration Services, despite sending in their application months ago. Until they receive the proof of application, they are left without access to affordable health care and therefore cannot seek out both necessary and preventive care they need in order to lead happily and productive lives here in Maine. Some of our clients have access to free care provided at many main hospitals. However, I have noted significant barriers in accessing free care. I will detail more barriers in written testimony, but the following are just some barriers we have seen in our community. Many of our clients who are income eligible are not made aware of free care at hospital when receiving care or when they are dealing with billing departments. Many clients receive surprise bills for serving from providers who are not hospital employees or bills used for record keeping. Clients, when applying for free care at one of our local hospitals, are required notarize documents. This creates more barriers for those who had not have time to make multiple appointments to complete an application for those who may not have access for transportation. There is a lack of clarity when it comes to what is and what is not covered by free care. Some clients I work with have received bill for services they delivered were covered by free care, but later they come to realize that not despite being informed before service were provided. Based on this experience, I urge the office to look into closing coverage gaps for immigrants. As an organization, Maine is appreciative Medicare expansions that have allowed for coverage for pregnant people and those under 21, regardless of documentation status. Further restoration of this coverage would allow for many of our clients to get Medicare coverage, therefore perhaps allowing them to seek out medically necessary and preventive care in early stage of illness at lesser expense. Secondly, I encourage the office to expand and improve access to hospital financial assistance programs. Increasing the federal poverty level income limits that patient must fall below in order to qualify would expand free care coverage for some immigrant family. Some main hospitals already go up to 200 fee PDL, but requiring all hospitals to do so would help enroll more people in the program. The ability for people to receive care sooner will help lessen the financial burden on both the clients we serve and the hospital serving them. By reducing application barriers, language barriers, and barriers increasing accurate, timely information, more immigrants will be able to enroll in the free care program. The care that they are income eligible for and need to get to stay healthy. I appreciate the opportunity to provide these comments and look forward to work with the Office Affordable Health Care to address a specific barrier faced by immigrant community associate state. I'll be happy to answer any question provided further information. Thank you so much.
Thank you very much. Much appreciated. So Helen's coming up next, and then it will be Hank Gorhus.
Hello, everyone. Good morning. I'm Helen Roy. I am the Education and Outreach Coordinator at Consumers for Affordable Health Care. So, Consumers for Affordable Health Care, also known as CAHC, C-A-H-C, is designated as Maine's Health Insurance Consumer Assistance Program, a CAP. As such, CAHC delivers CAP services statewide through three components. We have a toll-free helpline, 1-800-965-7476, which is staffed by trained experts in eligibility and enrollment in private and public health insurance. And our experts also provide in-person enrollment assistance when it's necessary. We have outreach and education. I did a webinar yesterday about safety net when someone is dealing with an insurance gap, a coverage gap. And then we also do private insurance appeals and grievances. So in 2022, Maine's CAP fielded nearly 6,000 calls from Mainers to our toll-free helpline. Consumers regularly report affordability as a health insurance coverage barrier. Reasons include high premiums, out-of-pocket costs, high deductibles, and inadequate prescription drug coverage. The following stories from just a few people who reached out to our helpline illustrate the affordability barriers many Mainers face and the difficult choices they make. So we talked with Dan from Androscoggin County, who was 25 years old, and he could not afford private marketplace coverage. He asked about catastrophic coverage, but that would mean he would not have access to premium assistance and would need to pay for all of his health care until he reached a deductible of $9,100. Anne from Kennebec County was prescribed an inhaler to help control her asthma, which would cost her over $100 a month, even with insurance. She could not afford the inhaler and is going without. Jason from Waldo County was recommended for a PET scan. His oncologist wanted to rule out a cancerous tumor as part of his ongoing cancer treatment. Even with coverage, he found it extremely difficult to ascertain what the cost of the scan would be, even if provided by an in-network. Over $4,000 once he reached his deductible. Amy in Piscataquis County called because she could not afford coverage through work and did not qualify for premium assistance through the marketplace. She wanted information about indemnity plans. After some research, she discovered that such plans could result in higher premiums and deductibles and do not need to provide ACA compliant coverage for preventive services like a mammogram. She also learned that such plans had a different process for accessing coverage. They may require the consumer to pay for services up front, possibly resulting in high upfront costs, and submit a claim for reimbursement. CAIC assists consumers both in enrolling in coverage and in challenging denied medical claims for coverage, another type of affordability barrier. Since 2015, we began documenting coverage denials and other billing issues. CAIC has helped recover at least $1,412,897. Two examples illustrate the scale of these barriers. A carrier denied coverage for an $824 pre-op medication for a patient's colonoscopy. The medication should have been covered entirely as part of the consumer's preventive care package. Instead, the patient received a bill. Though the bill was not huge, it was significant to the consumer. In addition, he spent many hours taking time off from work attempting to resolve the issue. A provider referred a patient who needed an unusual course of treatment for a chronic disease to our helpline. This patient's insurance company denied coverage for the treatment in both the provider's appeal and a level 1 consumer appeal. After a level 2 appeal that required over 120 hours of research, communication, and advocacy, the treatment plan was approved for coverage. The total cost of the medical care was $86,280. If the claim had been denied again, this consumer would have had to go without the life-saving treatment. So we hear from many Mainers who face impossible choices to forego treatment, pay hundreds or thousands of dollars in medical bills, or end up with significant medical debt. When healthcare is unaffordable, consumers are placed in an impossible situation. Mainers need relief from the high cost of healthcare. I urge the Office of Affordable Healthcare to make recommendations that would protect consumers from unnecessary medical debt, and that would result in a reduction in cost of healthcare and prescription drugs for users. Thank you, Meg.
Thank you.
I'm glad to be here. Thank you.
Thanks for being here. So we'll have Hank next, then it will be Ann Willison, and then Maine Medical Association, and then that's going to close out my list of folks that I had signed up in advance. I'll open it up after that if there's anyone left, but just to give everyone an update on how we're doing time-wise.
Thank you. My name is Hank Goyes. I'm a physician from Auburn, Maine, and I'm here to speak as a provider. I'd like to submit 2 articles, which you may have in PDF, and we'll probably share with the commission, and will be available once you get your public website up available. I'll have some copies of my comments there because I was thinking it'd be like testimony at the State House or something where you all want copies, but there you go.
I'd save some paper today, so thanks though.
So I'd like to submit these 2 recent articles and an analysis regarding the complexity and cost for providers in our current system, with an emphasis on the magnitudes of the problem, because I like pictures, so that's why there's a lot of graphs with our current healthcare system. Specifically, if your group considers the broad availability of an independent or a private practice provider as a positive care model in Maine's future, you may want to consider the system we have now and any changes. The first B chart is a data point number 1. This is an international comparison. Sorry, but we have to make international comparisons because that's what medicine does. We compare care across the world to see which is better. Is from an article in the Annals of Internal Medicine from July 2018, showing that clinical notes in the USA are nearly 4 times longer than the average in other countries. Graph available. Other countries here, US notes here, which is the workload for your average physician. So when your physician is looking at the computer, not you, you realize he's making 4,000 characters per note, as opposed to everybody else in the world does 1,000 characters per note. Meaningfully, it seems, the article's analysis, meaningful use incentives have unintentionally created requirements for substantial low-value documentation. EHR vendors, these are some quotes from the article, EHR vendors have disproportionately focused on developing robust financial and compliance features as U.S. hospitals, and I think they would care as a marker for physicians also, or providers in general, As U.S. hospitals demand features in search of financial sustainability in a market with seemingly insatiable needs for documentation, for the value-based rubric that seems to be. In fact, fee-for-service may not drive the bulk of documentation requirements. Several countries in the international analysis use fee-for-service as their model. After the article spends 8 paragraphs questioning the current incentives, it ends with a single paragraph going back to the rubric of value-based, in my opinion, because I think they have nowhere else to go, because they have no imagination. And I would hope that your work, you will consider finding other places to go. Item number 2, another graph, is from an article in Health Affairs, August 2022, Billing and Insurance-Related Administrative Costs, a cross-national analysis. Their bottom line was to bill out an inpatient chart in the United States, costs anywhere from $120 to $215, and they made an international comparison, and it turns out Canada is $6. They did a further analysis. They were able to break some of those entities in, and it seems that the coding is the major cost issue in the United States versus other countries that just have, if they have a somewhat private-public system, as opposed to, let's say, our more private system, their public-private system, as opposed to the more governmental systems, the costs go down. So the administrative costs for hospitals, and I think that's a rubric as for providers in the office, they did do an analysis, they referred to analysis where if it costs $6 in Canada and $215 to generate an inpatient case in a hospital, it costs $21 in the United States, but those previous studies didn't break it down into the various activity-based that they did, and they did a time study in this regard to generate costs. The study did not include billing costs related to the payers, the other side of the coin. Comparing national coding processes might offer some policy lessons for you, for the U.S. And they said just contractual reforms where you made every one of the contractual requirements for physicians, for providers to interact, if they're all uniform, might save anywhere from $900 to $2,100 a year on a $22,000 annual insurance premium. And their reformation is because these costs are deemed to add no value to healthcare delivery, they offer prime targets for reducing wasteful healthcare spending. So the back office part of the whole thing. The last sort of data point is, again, the idea about international comparisons of finding value. Their graph, I think, related to the cost related out there. So I'd say they seem to find value where we can't seem to find value. So there's, on my handout, there's 6 summations of what those other systems do. But to sum them up, I'd say that negotiations over financial processes are directed and resolved via the government prior to a provider interacting with the patient. All of those processes are done before I sit down in the room with a patient. So the idea of all of those other processes are done prior to a provider interacting and caring for a patient. So when you do your analysis and your considerations, I would recommend that you consider going places.
Thank you
Thank
very
you.
much. Appreciate it. So next up, Anne, and then it'll be MMA on deck after
that. Thanks, everybody, for sharing your comments today. It's been really interesting listening to them and seeing you all too after so long. And thanks to the office for providing us with this opportunity to submit comments regarding barriers Mainers face accessing the healthcare they need and possible solutions. I'm Ann Wollison. I use she, her pronouns, and I'm an Executive Director of Consumers for Affordable Healthcare. You heard earlier about the role Consumers for Affordable Healthcare plays in consumer assistance, helping Mainers enroll in private and public health insurance, dealing with inappropriately denied health claims, and also referring people to other safety net programs to help meet their healthcare needs. It is through that experience and as a result of our survey data from last winter that I share these comments today. But before I get started on barriers and possible recommendations, it's really important, I believe, to acknowledge the steps our governor and the Maine policymakers have taken to address rising costs. The list is extensive, and I don't have time to discuss all of them, but really need to acknowledge the importance, for example, of Medicaid expansion, Medicare expansion in the state, where over 109,000 Mainers have access to coverage who would otherwise be uninsured or underinsured. It's important to mention a couple of other steps that you've heard about today, the ability to receive primary and behavioral health services without those initial visits being applied to a deductible, preserving access to reproductive health services, expanding children's eligibility under MaineCare services, and expanding eligibility under MaineCare for children and pregnant people regardless of immigration status, and the creation of this office and a state-based exchange. All of these things are efforts that our legislature and policymakers have taken to try to address rising costs. And while progress has been made, however, as we had heard today, Mainers continue to experience affordability barriers. And earlier in Meg's presentation, she discussed a lot of data points that were found in our survey, so I'm not going to repeat all of them because she included a lot of them. But just to acknowledge that, just one medical emergency would put many Mainers in financial crisis, and that nearly half are experiencing some kind of medical debt, and 1 in 3 Mainers have experienced calls from collection agencies because of a medical bill. Most of those medical bills coming from a hospital. So it's clear that Mainers are struggling to afford the healthcare they need. And I'm just going to touch on some of those barriers and just really quickly talk about recommendations and then submit more detailed comments by the comment deadline, which I believe is October 6th. So rising medical and prescription drug costs, we've heard about that from a number of people today. The Maine Health Data Organization reports that last year, Mainers spent over $158 million for the most costliest drugs in Maine, and that is on top of $170 million they paid for the most costliest drugs the previous year. It's just unsustainable, and it really does force people and payers to make very difficult decisions, and also decisions on their neighbors, whether they can put food on the table or fuel in the tank or purchase the prescription drug that they need. Unaffordable insurance premiums and out-of-pocket costs, a lot has been said about that today. Again, people making difficult choices about whether to purchase the coverage they need or be able to provide basic needs for their family. Gaps in eligibility coverage. We heard today a lot about the ability to expand MaineCare coverage, restore that coverage for immigrants regardless of immigration status, especially pregnant women or pregnant people or and children. But when we talk about making sure that everybody in our state has access to coverage, that means that we need to restore that coverage that was provided before 2011 to all Mainers regardless of immigration status. We found that in our survey that 2 out of 3 Mainers support that initiative. They want coverage for everybody in the state regardless of immigration status, and by doing so, our healthcare providers, our hospital systems, and clinics would have additional resources for services that they're providing to people that they're not currently getting reimbursed for. So there's a bunch of policy recommendations that we will go to in much more detail in our formal comments. But again, closing the coverage gap for immigrants, which I just discussed, providing continuous eligibility under MaineCare for children like other states have done, Oregon and Washington, for example. And I believe somebody mentioned, maybe it was Kevin, trying to improve the transition from people who are losing their MaineCare coverage to marketplace coverage. Anything our state-based marketplace could do to smooth that transition would be very, very useful in preserving coverage for Mainers. Expanding and improving access to hospital financial assistance programs. We hear from people every day who are utilizing those financial assistance programs, which we appreciate very much. We also hear every day from people who face significant barriers accessing those financial programs. So anything we can do to improve access to those programs. And we're just going to hear a little bit more and hope that we can provide greater protections against what we see as harmful medical credit cards that are routinely advertised as interest-free, but come to find out that if a payment is missed or a payment is late, those medical credit card companies can charge interest on the original amount, and we are hearing from people who are facing incredible debt as a result of using those credit cards. Policies to address rising medical and prescription drug costs, utilizing Medicare reference pricing. We have seen from the federal government the list of drugs that are going to be negotiated under Medicare Part B. And when you look at the most costliest drugs that Mainers are paying for, all of those drugs are included in the Maine Health Data Organization's list. So just trying to figure out what we can do, especially with public payers, taxpayer dollars, to rein in those costs. I think doing more to provide access to effective generics and biosimilars would be helpful. Prohibiting anti-competitive practices by dominant healthcare systems. Limiting facility fees and limiting facility fees for certain services in certain settings, ensuring the alignment of silver premiums for ACA compliant plans, limiting cost sharing requirements to make them more reasonable so people will be more encouraged to purchase coverage, increasing the standardization of clear choice plans, strengthening Maine's rate review process, providing state-level subsidies. And I know that you talked about that earlier and how we don't want to just keep subsidizing high costs, but anything we can do to increase our pool like other states have done so those costs are distributed more evenly. And that would result in less cost shifting, I think should be explored. And then finally, really thinking about, and I know that Meg mentioned this earlier, thinking about what a public option health plan would do in terms of increasing affordability and creating competition in our state should also be explored. So I won't go on, except for to say public options are being looked at in Colorado, Washington, and Nevada. I appreciate the time to be able to talk with you all today and really appreciate all of your thoughtful comments.
Thanks, Ann. I apologize for co-opting your data points.
Morning. I'm Paul Kane, MD. I'm a retired orthopedic surgeon from Oxford, Maine. I spent my entire career at Central Maine Orthopedics in Auburn, serving the people of Central and Western Maine. I'm pleased to be here today in my capacity as president of the Maine Medical Association and to share MMA's recently adopted revised statement on reform of the U.S. healthcare system. The MMA is a professional organization representing more than 4,000 physicians, residents, and medical students in Maine, whose mission is to support Maine physicians, advance the quality of medicine in Maine, and promote the health of all Maine people. The MMA Board of Directors adopted the following statement, which will be submitted on June 7th, 2023, after a lengthy process of soliciting member input in developing consensus in our diverse membership. This was no easy task. The MMA has a standing policy in support of universal coverage and access to healthcare since the early 2000s. So this statement documents the evolution of physician attitudes about the U.S. healthcare system and clearly demonstrates widespread frustration among our members with the status quo. The most recent healthcare reform initiative began in early 2021 when our board of directors established an ad hoc committee on health system reform to review and revise our previous statement adopted in 2017. This committee undertook a 2-year process of seeking opinions of MMA members through surveys, listening sessions across the state, and meetings with group practice members. The ad hoc committee developed an initial revised statement, which was distributed for comment, followed by a second draft, which became the recommended revised statement to the board of directors. The board, as the governing and policy-making body of the MMA, reviewed, debated, and further refined the statement over several months before it was adopted on June 7th, 2023. I feel comfortable saying that this is truly a consensus document and in the true nature of compromise represents many board members and individual MMA members' best second choice. Our MMA's 170th annual session during the weekend of September 8th focused on healthcare reform. The statement was presented to the general membership at this meeting on Saturday, September 9th, and it received near unanimous support. I believe there is one vote not supporting this. Out of the entire memberships that attended that meeting. At our next board meeting, MMA leaders will consider the formation of a steering committee to guide the organization through a statement implementation phase. We will continue to engage our members in the healthcare reform debate at the state, regional, and national levels, and we will look for opportunities to collaborate with our elected representatives and other stakeholders in pursuit of the principles and goals articulated in this statement. So thank you for considering my comments regarding MMA's newly revised statement on the reform of the U.S. healthcare system. And I would be happy to respond to any questions you may have now or in the future. Thank you.
Thank you very much. So that is everyone that I had signed up to speak. Are there any other takers in the room who would like to provide comment? Didn't think so. Looking around at familiar faces. So with that, I can wrap up for this hearing. Just want to say thank you again to everyone for being here, for joining online. I know it's a big chunk of time out of everyone's day, and a big special thank you to folks who came and testified who may not be acting in their professional capacity, who took time away from work and life and other priorities to be here and to share their personal experiences and perspectives. That is truly very much appreciated. The last thing I'll say is just one last reminder about the submission of written comments, especially if folks drop them off with me. Great if you can email them as well so I can track them, but look forward to more robust comments and being able to flesh out some of the points made today, as well as hearing from folks who joined virtually but weren't able to attend in person today. And just looking ahead, a few notes on the calendar. Again, we'll be compiling a report that will be delivered to the legislature and the governor at the very beginning of the new year that will incorporate these comments, as well as summaries of the office's work to date. Another quick note, there are some advisory council meetings coming up for folks who have joined here. Again, those are open for the public to attend and listen in on. There is one on October 17th in the afternoon from 1 to 3 here in this room, and another December 19th. And it is possible to view those remotely as well if you'd like to. I will add everyone who attended virtually or who's signed up to comment, make sure that everybody is on the interested parties list to receive the recording from today, as well as the slides. And that group is where we share information about joining those advisory council meetings, as well as through help from Colleen, who has been sharing that with the HCIFS interested parties list. So Kim, did you have
Just a quick question. So I know your website isn't up yet. So where will we all be able to view those comments that are submitted on or by October 6th?
I am hoping that by October 6th, my website will be up. The URL I can share now so folks can write it down to be checking on it. It'll be maine.gov/OAHC for Office of Affordable Healthcare. In the absence of that, I may collaborate with DAFS or others to find a way to be able to put that up somewhere else on the State of Maine website. But I'm really hoping we are close to the finish line and we can post it there.
Thank you.
Sorry if I missed it. Do you have any insight into the November convening that you've talked about with the advisory committee before in terms of dates or things like that?
Yeah, hoping for the 15th, but more to come on that.
Okay. Pencil, not pen.
Yeah. All right.
Thank you.
Okay, thank you again, everybody. I will close out the Teams meeting, and I hope you have a great rest of your day.